Hi, everybody, and welcome to Multidisciplinary Success, Boosting Collaboration Across Care Teams. We are so excited that you have joined us today. My name is Shannon Hill. I am the editor-in-chief at CR Institute. My background, in addition to behavior analysis, I actually started in this field in intellectual disability services, specifically adult intellectual disability services. And when I was starting out in all of that, a lot of the questions that we are asking ourselves in behavior analysis now around collaboration are things that group was addressing 20, 30 years ago as I was becoming a part of the field. And so a lot of what I'm going to be talking about today comes from my experience there, where I was shaped to see myself as a team member before I was identifying as necessarily a behavior analyst. So I'm really lucky in that that is how I came up through the field, and I'm excited to kind of share some lessons that were learned there. And not to say that everything was perfect and wonderful and that it all went smoothly. But again, when you learn some lessons some hard ways, it's sometimes nice to go ahead and share those with others and see if we can find easier routes as we are looking our way through this together again. And my co-host today is my Behavioral View podcast co-host, Nissa Van Etten.
Hi, everyone. I do feel like we're recording an episode of the Behavioral View because we're on this together. My name is Nissa Van Etten, and I am a clinician by trade, but also have experienced a lot of these collaborative approaches that Dr. Hill is talking about in regards to working in a multitude of locations. I started in the field as what you would call a tutor. So working in homes hired by parents. This is pre-insurance reform. So I was working in a number of locations where the parent was my supervisor, which seems so odd when you think about what happened 25 years ago, but also had like a master's level supervisor. So this is going to be a great conversation. I'll bring in my experience and also some of the things that we've been reading in the literature related to collaboration.
So, our agenda today, we're going to define some major approaches to team collaboration in disability services, look at the usefulness and limitations of expertise, and discuss some ways to create collaborative environments while identifying skill sets that we may want to develop in ourselves and other team members. We will have some time for live Q&A at the end, but again, if you have questions as we go along, we're going to keep this informal. Go ahead and drop those in. Whoever's not talking may answer in the chat directly, or we may just bring your question live. All right. So let's kind of launch in and talk about some approaches to collaboration. So there's been a lot of work done on the concepts of working together. And you'll see language, depending on where you're reading, that may seem to be saying the same thing, but actually has slightly different connotations. So you may see it referred to as multidisciplinary, interdisciplinary, and occasionally you may even see the word transdisciplinary. And I like these graphics to kind of show what the differences are between those. So for multidisciplinary, that is talking about people who are coming in with their own perspective or their own training and working kind of independently, but in parallel. And that doesn't mean that we don't communicate. We absolutely do. But everybody is doing their own thing and then reporting back into the middle. Whereas with interdisciplinary, you still have a group of professionals from various different disciplines that are working collaboratively. But instead of just everyone taking their piece and working independently on that, they're bringing some of their processes and procedures and their expertise together, sharing it and integrating it, and working together to solve problems that are more holistic. And then if we go all the way to the most integrated version of collaborative services, we're talking about transdisciplinary services. So this is really hard to do. I'm not going to lie. It does take some understanding of not only your own discipline, but what others are bringing to the table. It takes some ability to feel comfortable with saying, I don't know, and maybe letting people in to what you're thinking and what you're doing and giving and receiving feedback. But basically, we're transcending the boundaries. We become more than just the behavior analyst, more than just the SLP, more than just the OT. We are looking at large goals and thinking about ways that not only can I help to help this person to achieve what they're trying to achieve in their life, but I can look into what others have to offer, and I can receive from those other disciplines some guidance on how I might be able to help them, and also how they may be available to help me. So we're going to dive in a little bit deeper on those because I realize that's still a little bit vague. So we're going to be talking back and forth a good bit about some of these options. And Nissa, I think this is your slide, was it?
Is.
Okay.
Taking it back to the three different kind of approaches to collaboration that Dr. Hill talked about, one of the things that we can learn, and I think as behavior analysts, and I'm speaking from a behavior analytic approach because that is my certification, so we can look to some of the other health and service fields that we might call the allied health professions, so nursing and medicine. And here what we have is just when you look at the literature, the core competencies for interprofessional collaborative practices. And this was done by a group that is they call themselves the ICP, published in 2016, and they worked with the Institute of Medicine, the National Academy of Medicine, and the World Health Organization to really provide kind of just some core competencies that practitioners should consider when they look to collaborate, whether that be, in that interdisciplinary model, transdisciplinary model, which I think is the ultimate gold standard. But they talk about an inclusive culture, right? Having open, respectful dialogue that is welcoming to other professionals. They also talk about having an exchange of information. So some way to communicate with these other service professionals, and then clarification of values, preferences, and communication styles. For this point, I know in my experience in working with a number of other professionals, SLPs and OTs, the first kind of conversation is typically one, consent from the parent, and second is an email introducing myself and then asking, would you prefer a phone call, a video, Zoom, an in-person meeting, or just email back and forth? And I think that's that first kind of step to saying, hey, I want to work with you. I'd love to get to know who you are in result to serving this client, and how can we communicate? The third competency is a team-based and client-centered approach. I think that, again, with that transdisciplinary model, being sure that we are participants in a team, but for the ultimate outcome of that client who's the center of our care. And in doing that, developing a comprehensive and collaborative practice there in that team-based and client-centered approach. And then lastly, in displaying these core competencies to work with other service providers, it's the outcomes. I think we're all here for those outcomes, and that's outcomes that relate to the client that we're serving, but also increased quality of that healthcare or client care that's delivered, improved client outcomes, enhanced work life for professionals in the collaborative model. I think that's one that we don't talk about often. If we have a great collaborative relationship with other service providers, our work life is enhanced, right? If you're working in a multidisciplinary team in an organization where you've got a large number of other professionals, you look forward to going to work and collaborating with these individuals. And then lastly, it's that optimized cost of care, because you are having fantastic team meetings and conversations about the client and the ultimate outcomes for that client.
Now my slides don't want to progress at all. Okay. So one thing that I thought would be helpful would be to kind of walk through an example case, because I know a lot of times we're talking about some pretty high level concepts. So let's think about this from the perspective of if we were sharing a client together. So we're taking the case of Alana, and this is all hypothetical, but Alana's 8 years old, non-speaking, academic level PK to kindergarten, no dangerous behaviors, but some annoying ones. So the high-pitched squeals when excited, which causes some issues for the family, and that sibling attention is very exciting. So she frequently squeals a lot at home, and seems kind of unaware of the environment. So not taking cues that this is, that there's other things to be paying attention to when feeling very excited. Alana has a communication device with about 8 commonly used phrases, but overuses those attention phrases. So it's often taken away or ignored when it becomes repetitive. She frequently requests help with self-care tasks, and that is 2 parts. One, that she seems to the family to prefer help to personal accomplishment, and also but lacks some of the fine motor coordination to perform many of the skills that are required for it to be done independently. But Alana is friendly to everyone, very receptive to adult stranger approaches, and also will approach unknown children. So you guys are welcome to kind of drop some ideas in the chat for the next question, but I'll put Nissa on the spot to be the spokesperson. What do you think is important to Alana, just based on that little bit of information right there?
Gosh, there are a number of skills. And one, I always say this when I think about evaluating and programming and working collaboratively. Speaking to caregivers and understanding, right? Like I have an idea of Alana's needs from my observations and my direct interactions with her, but also trying to understand stakeholder social validity. What is important to the caregivers and the parents, or the school setting if she's in a school setting. So I can really look at what is the priority for intervention and treatment. But again, just from looking at Alana's profile, and I'll remind some of us that were listening, right? We've got some high-pitched squeals, communication device with some phrases, frequently requesting help with self-care, but friendly to everyone. So one, I would look at increasing communication, right? Making sure that we can have her needs met. It looks like she frequently asks for help, so expanding upon that. Using the device, making sure that she is able to capture attention, especially to replace some of those squeals. And then the next one, I look at that friendly to everyone, and I'm concerned a bit with safety. Are we aware? Are we in close proximity to caregivers, instructors? When parents take her out into the community, does she stay nearby? And is she aware that parents might be moving? So those are some areas I would begin to evaluate for Alana, but I would also speak to the rest of the treatment team to see what they're seeing when they're working with her. If she's in that school setting, so she's got the PKK level, what's happening at school, teacher? How can I support? Here are some things we might be doing in a clinic or home-based setting if I'm not working at school.
All right. So one of the things that I think is really helpful is to bring all of this back to something called the person-centered model, which we'll talk about. I think I have slides coming up later on that. But based on just Nissa's off the cuff, we didn't practice this. So Nissa's off the cuff explanation and answers to my questions. When we work from a person-centered perspective, the very first thing that we do is look at it, amazingly, from the perspective, as much as we can, of the direct client. And then the second level is to look at it from the stakeholders that are permanent in Alana's life. Third level is what these practitioners and team members see and believe, and what their assessment results say. So when we look at Alana, we know that Alana can't verbally tell us what is most important to her, but through her behavior, she's already given a lot of information. We know social interaction, just from that little bit of information that we have right there, is super important to Alana. Attention is a big deal. And so as the entire team, not just behavior analysts are looking for that very thing. What's reinforcing to Alana? So is everybody else. They just may use different terms whenever they're describing that. But if we are all keeping in mind that attention and social interaction are the key motivators for Alana, then it changes what everybody's doing. And so when we think about something like the high-pitched squealing is very annoying, we would like for that to stop. Then we immediately go first Alana needs to have the level of social interaction that she is wanting. She needs to have the contact with people that she's wanting. And everything that we're going to do is going to drive to get her there. And then when we look at that next level at the stakeholder, people who are going to be in her life permanently. So we're looking at siblings, we're looking at parents, we may be looking at grandparents. We are going to say, okay, now that we know what Alana wants. Alana wants attention, she wants friends. And she wants to communicate whether she's finding the most adaptive ways to do so or not. So far, that is clear that that's a want for her. What do we want? Well, that family is probably thinking things like, we want Alana to be happy, we want Alana to be safe, we want Alana to communicate. We want her to be more independent in her self-care skills. And then we want her to be okay. We want her to notice if she's in a dangerous environment. We want her to notice if she's in the movie theater that squealing is not the right time and place. We want her siblings to be able to walk away without feeling guilty. We want them to be able to have friends over without them being annoyed by these sounds. So it's this structuring of what's important to Alana, what's important to them. And then we come in with, as the behavior analyst, as a speech therapist, as the occupational therapist, the special education teacher, whoever we are, the mental health counselor, what are my tools and my perspectives and my analysis that can feed into supporting those things? What are the component skills to this? What are the prerequisites? And what are the procedures I have that I can add to this scenario? So let's say that we do start with that, which I know a lot of times we don't, right? We don't start with that big picture. We may receive a document that is full of like the psychologists and the psychometrists reports and where we're going to go from here. So I'm going to take you through the 3 different approaches and how that might look a little bit differently based on what approach you're going with. So let's say you're in a multidisciplinary approach, which, by the way, I want to say something right from the beginning. I'm not here to judge if you are multidisciplinary, interdisciplinary, or transdisciplinary. As Nissa said, gold standard is transdisciplinary. It's where we're all trying to get. But if you want to go all the way back to like Maslow, where self-actualization is the goal, we don't all always get to that. The thing to be working towards is, how do I move towards this? So if you're at the multidisciplinary stage right now, great. Let's be the best we can at that, and let's start reaching towards ways that we can become interdisciplinary. If you're interdisciplinary, how can you start reaching out to grow it towards transdisciplinary? So that being said, if we're multidisciplinary, this is the easiest lift for individual team members, and it's probably why we default to it the most. Everybody is coming in, and we still have that learner at the center in this graphic, but it's like everybody has an individual relationship with that learner. And the deficit of it is we lose some of what is known to be helpful in making a team work via team dynamics. If we are only getting together, if we're only communicating at IEP meetings or IFSP meetings, whatever those pre-scheduled times are, then we probably don't have enough time to get this lift of all of this team that knows each other and understands each other and supports each other, if that's the only interactions that we have. So what Nissa was just saying about being able to communicate outside those sessions, whether that's a Zoom meeting or a phone call or whatever, is going to help to kind of build those relationships more. When you are multidisciplinary, whoever is that team leader or case manager has a lot more responsibility than you do if you are in an interdisciplinary team or a transdisciplinary team, because that person's role is to make sure that we're not at odds unintentionally. I don't know about you, but I have been on the receiving team of some compiled reports where I have flipped through, and maybe the psychologist says these are strengths and these are areas to grow. And the behavior analyst may say, these are strengths and these are areas of growth. And the SLP and the special education teacher and the occupational therapist, everybody has those. And sometimes when you're going through, you see that one discipline might have it as a strength and another might have it as an area for growth. Some people might see it as an advantage, and some people might see that there are different parts of this skill that are missing that don't get picked up on in other people's assessments. So that is one really big area that we can grow in if we are multidisciplinary, is if everybody gets access to those reports and reads them from the perspective of the parent. If I was reading this as a document, and it's already kind of a long and arduous journey through those documents. If all of the team members have read through those and looked for places where we're contradicting each other, or maybe we seem to be, to someone who doesn't have that specific training, and then go back in together and be able to communicate and say, why did you say this was a strength when my assessment says it's a weakness, and find out what that explanation is, come to the table with that ready to go, or revise the report so that it's clear. The other thing that we're at risk for is if everybody has a standard set of assessments that they run, and we just fill out those reports and we compile them one after the other, we're at risk for, if we didn't have that first overarching question from the family, how can we better support this thing that they want, then we're at risk that none of us assessed it. All of us have multiple assessments that we can choose from, and we might default to using it based on verbal skills or age or just what our training is and what we have in our closets. But if we know on the front end, this is a family question, this assessment isn't going to get at that, but there are others that will, we can make those adjustments on the front end. And then the big one down at the bottom. I've been in a lot of multidisciplinary team meetings. I have not been a parent in one, but I have tried to look at it from the parent perspective. And I often see that those parents and the client are treated as recipients rather than actual team members. So they come to the table not knowing what's in that report a lot of the time. This is the first time they've heard that. They don't even have the opportunity to kind of look through it and say, these are my questions. And I think that's the main deficit. Note, though, everything that I just pointed out as problems with multidisciplinary approaches can be adjusted. You could go ahead and do all of this on the front end. I know it's work, and some of us may not even have a reimbursement strategy for that work. These are things that if we go ahead and we embrace them as best practices and things that we want, though, we can change our field, and we can change and advocate and lobby for getting those things approved. So this is just kind of another way of looking at that if you're doing this multidisciplinary review, the social worker is coming with their assessments, the occupational therapist is coming with theirs, and so forth and so on. And from all that, we may come away with a plan that looks kind of reasonable. And one thing I want to point out is, although the plans are going to look differently in format and form at the end based on the approach that we take, you're going to see some duplication in what actually happens at the end. So this doesn't necessarily change what services you render, but what it will do is make sure that we're focused on the same things and that we are helping each other and integrating it so that the plan of care is more holistic around the client. So in this multidisciplinary plan for Alana, we may have that Alana is going to participate in self-care skills training, making sure that we're integrating praise and sibling attention and all of those things, and that she's going to use her communication device to expand conversational skills. That would be the overarching plan. Occupational therapy would have their things. So some examples would be grasp and grip, working on those self-care skills. Speech therapy, we may have the same kind of services where we're doing 30 minutes once per week, working on device, working on manual signs, attending group sessions. And in ABA, we're probably going to do some things related to communication as well. Maybe building in some weight tolerance based on the things that we've learned so far, and working on the volume of those squills. So all of those goals do align with what we were seeing before, even when there's not a whole lot of communication on the front end, as long as we've got that high level picture. However, if we step that up just a little bit and look at it interdisciplinary, what you have now is the same little graphic on the side, except that instead of just arrows going from the student, the client, the learner, whatever language we're using, we are also having communication between and amongst all of us. So we are reviewing those assessments on the front end. We're working together. We're making sure that everybody knows what the high level goals are, the life goals, what Kristen Smith, who's on our team, talks about as those macro level goals. So what are the big things? We still are all choosing our own assessments. We're writing our own reports. We're implementing our own instruction, but we're reviewing those and we're collaborating on ways that, if the speech therapist isn't getting a lot of traction because of maybe some behavioral issues, then we're knowing that on the front end. And maybe we're able to communicate with them to talk about some prompting procedures, some reinforcing procedures that are working in our sessions that we can transfer over to them. If we're stuck on the AAC, then we know we can go straight to the SLP and say, how do we decide? How do we select? How do we teach? Those things that we weren't specifically trained in, for example. So all of this turns into more integration, more awareness of what everybody else is doing, but it still often turns into what I call the handoff method if we aren't really conscientious about communicating with one another. And that means that once a behavioral issue is interfering with skills training, oftentimes it may get handed off to the behavior analyst. We're going to get that under control, then we're going to come back here, which is sometimes going to be necessary. But if we are having this tight group dynamics and communication, maybe instead of it being a pause on this goal until we get the behavioral under control, maybe the RBT goes into those sessions and runs their sessions parallel or within and models what that reinforcement looks like. Maybe the behavior analyst comes in to see if we need a new functional assessment based on this setting. So we still have some risks if we're not only just reading behind each other, but communicating with each other on the front end of where those issues are coming in. And then lastly, we still have some issues with parents and learners often still being treated as recipients rather than those team members. But if we are really keeping them at the center, and if everybody is communicating what we're doing and integrating some parent training things into, here's how I run my session, here's some things that you can do at home that would parallel and support this, then that is another way that we reduce those complications. Nissa, I'm going to take a breath for just a second.
Yeah,
Can't see the Q&A. If there is any, do you need to interject?
nothing in the Q&A, but I do have some thoughts as I'm listening to you talk about the different approaches. And I think from a clinical perspective, especially being a behavior analyst working, in a clinic-based setting, for example, the question is and this might be more rhetorical and just something for us to think about as we walk away from this webinar, is how do we, in the type of setting that we work in, develop these approaches, right? I'm used to, again, that old multidisciplinary. I come in as the professional, I'm invited to the IEP, and this is kind of my role as the in-home or in-clinic behavior analyst. So I'm bringing in my experience, and then I'm working to become collaborative in my approach with others. But the interdisciplinary, and then when we get to transdisciplinary model, is hard because who is the case manager, right? And oftentimes that burden falls on the family. It is on the parent to say, hey, let me get my entire team of professionals together. Let me schedule a meeting for everyone to be present. And then let's make sure they all bring in how they're working on certain skills. And I do have some families I work with where they do a fantastic job bringing in OT, SLP, and then the mental health counselor. And we might meet once every quarter and just talk about one or two approaches versus like the entire holistic approach, because that would take a lot more time. And again, then we get to that conversation of billable units, who can bill for it? Is this something that we can even bill a funding source for? But again, in wanting to work towards that transdisciplinary model, who is the case manager? Who calls these meetings? Who coordinates? And that is a very different perspective in a insurance funded program versus like in a school where the teacher might be case manager and really gain everyone's scheduled time and bring them together. So I think about the barriers to moving into these different models. And then would love to see in the chat anyone who has done this and found a way to kind of bring these approaches to life pending these barriers.
I do think that there are multidisciplinary, interdisciplinary, transdisciplinary clinics that have developed and grown up. Like, this is our model, this is what they do. And the funding resources for that are something that I would really be interested in hearing about too, because the difference where these things come out of adult services, because the pay model at that time was very just single source, most of them. So you're in residential services, you're in waiver services. That means that you have this team of this that's wrapped around, and there is already an impetus on them to communicate and to make sure that it is interdisciplinary. And so the funding issues, when you're aligned with medical, I get frustrated in healthcare myself, because if I go to the physician, but I'll give a real example. I went to the physician because I was dizzy and it wouldn't go away. And the physician looked at me and said, well, it could be this, it could be that. I think that what you need is physical therapy. And so he sends me to the physical therapist. He's done with me. And there's no follow-up there, right? No integration, no communication with one another. And I think a lot of that has to do with exactly what you're talking about, that funding isn't there to pay them for that 5 minutes or 10 minutes that they're going to do to make this phone call, and certainly not for you to read a 30-page report. So when I think that it's just something that, as we begin to advocate and say we can get better outcomes from these types of services that are going to be more rapid, we have to show that. And then that you get funding to change. Is
And then
anybody?
just a couple of the comments in the chat very similarly is that funder barrier, right? In that, who is billing for this time? And I know I've worked in a multidisciplinary organization that had OT, SLP, and ABA. And this was prior, I think this was 7 years ago. So we could kind of all bill simultaneously. And I know that's changed dependent on your state, the funder, and those requirements. But I think the piece that I see, again, the burden being on the family, is if I'm doing a parent training session with a parent, and maybe I have a couple learners in home where OT is leaving and parent is present and I'm present, we can do a collaborative meeting, but then it goes into a parent training type session. But then again, when we think about funding sources and what we as clinicians should be communicating, is that again puts that burden on the family to coordinate that communication. And then providers have that question of, who bills for services? Will we recoup those if, SLP was there at that time versus ABA? And is there the dual delivery that's required? And I know some clients can receive that if, depending on, challenging behavior and needing support in other service provision. So those are some of the questions we're seeing come through.
Yeah. And again, we're teaching you some best practices here, some things that have been learned from other fields. And so we don't have all the answers to how you're going to get paid. How do I do this if I'm not getting paid? We want you to know first what best practices there are, what your choices are, how things could be done. And I guess maybe that's our next steps, is to be looking at some things that we can do to try to advocate to actually get paid for doing these things. All right. So what you were just asking about, Nissa, all of that, it's interesting that you are saying, it falls to the family to organize their team. In person-centered planning, it was almost seen as a coup to give that power to the family to coordinate that care. And or even, in the case of some adult clients, to give that power to the client, say, this is my team. You guys are going to meet when I say. Because in those service delivery systems, it's always been, okay, we're all going to come together. We're going to tell you what you need to be doing. We're going to sit around the table and everybody's going to tell you what their perspectives are on you. So when person-centered planning came around, the idea was to flip that. Oftentimes in those adult services is the social worker who is the case manager, and the family doesn't have to go and reach out to the occupational therapist, the speech language pathologist, the behavior analyst. They just call the social worker and say, I want to have a meeting. And these are the people that I would like to be there. And the social worker's job is to arrange for that. I think in the schools, that's probably oftentimes going to be the teacher who serves as that case manager, who takes that responsibility, pulling all of these people together. But for interdisciplinary, there is usually somebody who is designated as that team member to assist the family. And also make sure we're complying with the review requirements. Yeah.
When there's a comment in the chat, it's a great question. I think it's something that we'll get to in the webinar today, but in another state, they're allowed to bill for interdisciplinary training through behavioral intervention. So it sounds like the behavioral team and other service providers can meet, which is fantastic. But there is a problem with personality clashes of different providers. So this commenter is asking some recommendations. And I know as we get to the end of the webinar, there are some nice frameworks on how to work collaboratively with some of those other service professionals that you might clash with, or your colleagues or even supervisees might clash with, and how to evaluate those and develop those skill sets.
I love that question, and I get it every time I do this presentation. Normally, it is focused on the behavior analysts. And I don't know if that person asking that question meant that at all, but I do know that one of the issues I've seen coming into this is, at least I've been trained as a counselor and I've been trained as a behavior analyst. So in my counselor training, I was taught to stay behind the client, and the client leads, and I'm here to support. As a behavior analyst, I was taught not only to stay in front of the client, but to stay in front of everybody else. And that we have this very special expertise that is tedious and time consuming, and that a lot of other folks don't want to put that much energy in. That's the way it's explained to us. Okay. So I just want to clarify, I'm not saying that's true, but old school behavior analytic training often focused on, you have the best approach. You need to make sure that they don't fall into pseudoscience or unproven techniques, and you need to be leading the charge. This is something that behavior analysts are currently trying to moderate, right? These days, we are really focusing on that soft skill development that are, whereas as a counselor, I had to sit in trainings and I had to be observed by my supervisor, talking to someone who was angry with me, confrontational with me. And that training was some of the most important training I ever had. There was even an exercise where we had to sit in the room and we could say anything we wanted to except no in all of our responses, which was really difficult. So I think a lot of that just has to come with experience. And another thing is, as people become more skilled in their own discipline, you become more comfortable with saying, I don't know, I'm not sure. You've seen more things. You've seen other people's approaches work where yours failed. And that does train some humility. But I also don't always think people who are coming in with a strong opinion, it's necessarily that they don't have humility. It's that they just don't have the experience yet to say that they've seen something else work. Or sometimes that whole feeling that you need to look like you know what you're doing, or no one's going to trust that you do, gets in the way of that. So I think as we age as a field, as we build professional development on just how to talk to someone who disagrees with you, I think those are important things, and I think we'll all get better at that.
And I love this question. I know, looking at the time that we could make the rest of the webinar about this type of topic, but I agree. I think that as a field, compassionate care is becoming and has been a hot topic since Taylor and colleagues wrote the paper in 2018 on compassionate care skills. But one of the outcomes of that paper, well, again, a very small N of parents were surveyed on their perspective of behavior analysts and working with them. And two of the areas in which behavior analysts could improve one was not always establishing and sustaining collaborative and caring relationships. That was one of the biggest outcomes of that paper, and why behavior analysts should develop these compassionate care type skills. And the second was coming in as the expert, right? Coming in and having to prove that I have the answer to serving this client. So I think those two areas, and it relates to the question in that we can improve how we display empathy, how we listen actively, how we ask clarifying questions, how we say, here's what I heard. Did I interpret that accurately? Or here's how we can bring this into the treatment we're providing if it's appropriate for the learner in the setting that I'm providing services. But I think that's a great question and really perspective taking, right? As practitioners, whatever credentials we have is to understand, here's my perspective and my role in bringing it to the team, and how can I work with you for the best outcome for this client?
And, it looks like we're not going to get through this whole presentation, which is fine, I think. I do want to throw one thing out there though, because I don't want to just pick on behavior analysts. One of my early learning lessons on this matter was I was brand new in this role. And I was in an interdisciplinary team with a nutritionist who just had a strong personality, right? And didn't like something that was in a behavior plan, and was just really flippant. And in the middle of the team meeting, I felt sabotaged, like she was lining up everybody in the team to not be supportive of the behavior plan. And I responded not well with, I'm the expert and you're sabotaging, just said every thought that I was having inside my head at the time, which I shouldn't have. And my supervisor pulled me in and said, okay. She wasn't even in the meeting. She just heard about it because it was that bad, and said, you made a mess today. And so you need to clean it up. And I had to go to this person who was very dominating and domineering and all of that, and just talk it out, the two of us, and say, I'm really sorry. I should not have behaved that way in the meeting. And I had to, do that. And as I did that, she never said, oh, I shouldn't have said that either. But she respected that I came to her, and in the future it didn't happen again. We would have those conversations on the side before we had them in the meeting. And it kind of came into a joke. I would call her up and say, I've written this food thing into a behavior plan. What do you think? Are you going to sync it? But it's all about that personal relationship. It really is. All right, I won't go through all of this. I want to get on into the rest of our presentation, but the point being here that you notice that the top paragraph gets bigger and bigger. So the top paragraph is everything that we are all going to be doing together. And then the amount of time, the things that we're working on independently as practitioners get smaller and smaller. This remains the most important part because it's integrated. So a transdisciplinary, it's person-centered by nature. It takes a lot of effort, but when you've been a part of a really good transdisciplinary approach, you feel great at the end of the day. And the biggest difference is your first meeting isn't sitting around a table with reports that have already been written. Your first meeting, instead of 5 different intake meetings, is one meeting with the entire team where the family gets to guide, this is where we're going, this is what we need. And everybody's taking their own notes about what their pieces are going to be for that. And the assessment plan is an integrated report. It is not, here's your SLP report, here's your behavior analyst report, your psychologist report. All of those things still have to be written. But what goes to the family is this integrated report of, here were the questions you asked us. Here are our assessment pieces that relate to that. and here are the services that we can offer to get you there. And some of those may be optional. You know, we could go about it. If it's a language goal, the speech pathologist may say, here's one option, and we may say, here's another option, or we may offer 3 options within our own discipline, but it puts them back in that driver's seat. And it gets into more and more of these bullet points of very specifics now. So our organizing paragraph before is everybody's going to do this and we're going to talk to each other. But now we're getting very specific. The RBT is going to come to SLP sessions. The OT is going to, you know, consult with a behavior analyst on blah, blah, blah. It's spelled out who's doing what with whom and how and why. So how do we get there? Easy parts. We can start with a framework. Now this is not saying this is the framework, but it's an example of one. Nissa, you want to talk about this?
Sure. I think, you know, just the next couple of slides really briefly give a perspective from the behavior analyst in terms of how do we build a comprehensive approach for Alana in particular, in terms of what are some skills we're going to work on, and then even bigger picture, you can see the skills that are presented here. One, we want to compare these goals to key component skills. So taking the ABLES and AFLs, if you're using both, some of the assessments from Steve Ward, and then a scope and sequence of academic curricular. So then you're working also with the SLP, or sorry, the special ed teacher, to understand what is the comprehensive approach for this individual. And then what's nice about some of these is the access to them digitally, being able to share, right? Let me send you this assessment, just take a look. It's pretty straightforward. It's written in a way that you can understand as an SLP, a special ed teacher, and OT. You don't have to have that behavior analytic framework. And start filling in areas that you think this learner can or cannot do so that we can together provide this approach to treatment. And then those tracking grids, and the crux of what we do in behavior analysis and using grids and graphs to analyze data is we can see that those missing skills are going to help us decide where we want to begin instruction together as a team. And then lastly, problem behavior reflects missing skills. So even if there isn't problematic behavior identified, we should also be looking at, you know, behavior intervention plans, the FBA, to determine what are some of the variables that are controlling this learner's behavior and how can we teach or provide a replacement behavior that's appropriate as a team so it's being targeted in every location.
We just did an episode of the Behavioral View that's going to be released, I believe, Thursday, that's also working on collaboration. It's BCBA SLP collaboration. And one of the things that the SLP who was sitting in with us said was understanding the psychologist's report and how to interpret their scores made such a huge difference in her ability to do her programming. And so when you take that and you expand it into when the speech pathologist does their report and the occupational therapist do theirs, they are often using a developmental approach. So they have better training a lot of times than what we do in the developmental sequence of skills. We can bring in, these are the skills that we see are missing. And, you know, Partington's done a pretty good job, but even says it's not fully scoped according to the developmental sequence. It's roughly scoped. So once we have that out there, if these other team members understand how to read our report, and those tracking grids making it very visual, is very helpful. The more that they can say, oh, okay, so you need to get at this skill, but before you can do that, I've identified this skill that's missing in my report. So let's all team together and work together on that. So that's the whole point here in all of this. We can only show you what we do because we're behavior analysts, but every team member has the ability to bring something like this in. All right, so those are just examples of what we just talked to. So what's the hard part? The hard part is what that question was asking us before earlier, right? How do we get into all of these nitty gritty of the personal interaction skills? And when we think about what goes into collaboration, research shows a lot of different things. So on your infographic here, skills to develop in yourself and in your supervisees. Feedback and reflection, we've already talked about. How are you going to use your professional development hours and times in an effective way? So I know I've heard sometimes people just wait till the last month of their certification and they cram in whatever courses they can in order to get that done. Or we go to professional development, we go to conferences about things that we do really well already to stay current. I understand that. But if you can carve out a piece of your professional development to focus on these kinds of skills, then I think that's helpful. And you can find CEUs that are behavior analytic. If you're a behavior analyst, that's a big part of our rules, that it has to be behavior analytic in nature. There are people out there doing work on developing these collaborative skills, and we're working hard to bring some of that information to you and CR Institute in your CEU offerings.
All right, I'll take over here. I know we've got just 6 minutes left. So just a couple of slides here on, Slim and Reuter Yuli, actually, I have a typo there, really talked about it effectively in that collaboration among team members, members of any treatment team demonstrate efficacy and positive client outcomes, right? We've seen that from looking at other service providers, other allied healthcare professionals, but training in this area leaves room for improvement. Our poll here really allowed us to see how much training some of you have taken in this area, but the literature out there says that behavior analysts don't really receive training in how to collaborate effectively. So our next slide just gives a couple of recommendations. We talked about them earlier, but the IPEC framework for interprofessional competency talks about these 4 additional key areas in which we can develop these skill sets in ourselves and then evaluate them in those that we serve. One is determining value and ethics, right? Making sure that your value and ethics includes working well with other professionals and maintaining mutually respectful environments with shared values. Just going into that treatment team, knowing that one of your values is to provide ethical care to your client, which is required as a behavior analyst. Next is roles and responsibilities. I say this often if you've heard any of my trainings or webinars. Bailey and Birch in 2010 and then again in 2022 talked about the clarification of roles as one of the important areas in which behavior analysts should develop. When we go into treatment, this is who I am. Here's what you can expect from me. Here's what I deliver with my training. I think that is something that we need to remember when we go into these multidisciplinary, interdisciplinary, or transdisciplinary approaches, in that we need to acknowledge and communicate our role and the role of each team member at the onset of building that relationship. The third one is that interprofessional communication. Communicate in a responsive and responsible manner that's supportive to the team and client. So try and get back to them rapidly, make sure that they are aware that you are a part of the team. And then the last one, teams and teamwork, relationship and team building approach to ensure that we are looking at collaborative efforts. And then my last slide, I know we are at the end here, but one of my passion projects and my passions in the field of behavior analysis is really ensuring that we have a culturally responsive vantage point in everything that we do. We know that the world is becoming a very diverse melting pot of individuals across diverse backgrounds. So approaching collaborative opportunities by also considering culturally aware practices. And in doing that, knowing that constructs and opportunities play an important role in collaboration. So making sure that approaching these team building approaches with each of the different professionals, that we're looking at it from a culturally sensitive and culturally responsive lens, and also engaging in any sort of bias training and evaluation of your own biases so that you can be a participant of this team with an open mind, and that you can approach them in a professional manner that helps serve that individual who's in the center there, which is that client.
Well, we're not going to do the activities. These are embedded from not knowing, how much time that we would take, but I will leave them with you if you want to work your way through. We'll leave them in the recording, so I will flash them all up here. But basically, one of the things that we're working on in CR Institute are some ways to do some training that is a lot more applied and hands-on and scenario based. So some of the things that we're going to be coming to you with are things like this where you're actually not just going to listen passively, but be given these scenarios and some guidance in what would happen if you did it this way and that way. So here are some things that we're working on. And not only how does it feel, we said we were going to talk about the pros and cons of expertise. Entering in with expertise is important, but it's also the biggest way to offend everybody. So we have to be able to find that balance between showing that why we're there and what we have to offer versus sounding like we're know-it-alls and we think our science is better than everybody else's. And then the third one, conflict resolution. And it's big deal. And it is something that we're going to be offering quite a bit of work for you guys, either in your role as behavior analysts in supervising, but also for behavior technicians who are caught in the crossfires and need some practice with that. And yeah, I think that a lot of those things are generic. They're not necessarily specific to a field. So I think that people from other fields could benefit from these exercises as well. We do have some references for you guys. All right, we left a couple of minutes. Does anybody have questions that you've been holding back and just waiting? Are
I
there any
think
more?
we had a bunch that happened live, so we can skip to the last slide
All
here.
right.
And that's just a quick little prompt. If you are in the California, even Nevada area, anywhere close to LA, we are hosting CR Unite this year, and that's in a couple of weeks. Where we are bringing in our users, customers, and outside individuals to talk about the product as well as other content. So thought leadership sessions, continuing ed, we'll have a number of CEUs there. And you can see on our screen here just a couple of the topics: compassionate ABA for optimal outcomes, where we'll be talking about a lot of that literature and compassionate care that's come out; maximizing strategies for RBT training and retention with CR Institute. So how does our library and CR Institute and some of the great work that's coming out in the near future support RBT retention and training? And then really exciting, a live behavioral view episode that Shannon and I will be a part of, where we'll be talking about embracing diversity in ABA. And we have a panel of some of our customers and experts who will be joining us at that talk live, which will be really fun.
Yeah.
I know we're right up on time, but if you can stay and complete our survey for the post-event, just that gives us information. Like many of you, we love the data that we receive from those. So if you can stick around, that'll be automatically sent to you after this webinar. Thank you so much for attending.
Yeah. And one of the things, as we said, this is an ongoing series. If there are specific deep dives you want us to take going forward, let us know.